So almost the end of the day, everybody, and I won't keep you too long because I know you're all in a rush to get your glad rags on for this evening, for your evening out, and the celebrating all the awards that are going to be handed out this evening. So insurance safe staffing, today for me, I'm going to take you through what is the National Quality Board framework on how that is governed at a national level, and then help you to translate to having your own local strategy for safer staffing in your organisation, and then finally talk about some of the opportunities and what is available from us at the CNO Safer Staffing faculty to support you in delivering safer staffing. So at the very outset, we have to acknowledge that we have a supply versus demand reality that is there. Every year, we can see that our establishment requirements are being put forward in a responsible way, are using evidence-based methodology, and currently it shows that our establishments are increasing year on year by about 3.6%. However, our pipeline and our supply of nurses is increasing at about 3.1%. So that is a gap, and that gap has been consistent now for a few years. So today you have talked about tackling that in terms of increasing nurse training placements and places, recruitment in terms of our domestic recruitment strategies, but also international sustainable, ethical recruitment, about retaining our staff, and about leadership and culture. So I am not going to talk about those aspects. I am talking about the framework that we can put in place that can help us to ensure we have safe staffing strategies in all our organisations. So here on the left is the National Quality Board framework for safe, sustainable and productive staffing. But in order to explain it well, I need to take you back to the origins and when this all came about. And it goes back to about 2013 when we had the Francis report, which set out an array of recommendations following the care failings at Mid Staffordshire Foundation Trust. Amongst his recommendations was that the National Quality Board should be the body to oversee all safe staffing guidance for the future. We've always had safe staffing guidance, but it tended to be a consensus guidance. So a group of expert people sitting around the table coming up with what they felt was important. And Francis said this was no longer good enough. Our guidance had to be evidence-informed. And so the National Quality Board asked NHS England to provide an overarching guidance, which was published in 2013 for safe, sustainable staffing. At the same time, they commissioned the National Institute for Clinical Excellence, NICE, to produce specialty-specific guidelines. They did that using their tried and tested methodology to producing guidelines for all healthcare areas. And they published the adult inpatient guidance in 2014 and the maternity safe staffing guidance in 2015. And at the same time, they asked the National Quality Board to take back the production of the ongoing speciality-specific guidance. What they specifically said was that it was to follow the same format and template that they had set out in the very beginning. So it had to be evidence-informed. So the first thing the National Quality Board asked NHS England to do was to review the safe staffing guidance that had been produced in 2013 and the new safe, sustainable and productive staffing guidance that you can see here, the framework, was published in 2016. So 3 expectations. Expectation 1, very much about having the right staff. So about establishment setting, about using evidence-based tools and professional judgment. Expectation 2, about right skills, about making sure that once we have these staff, that we are providing them with the education, both mandated and desirable for those roles, so that our staff are able to care for their patients. And recruitment and retention strategies in place to make sure we're always looking ahead to have the right staff or the right numbers of staff in place and the right skill mix of staff in place, and we're always one step ahead where possible, but also importantly to look after our staff so that they will want to stay in the NHS. We absolutely want people to turn over and move and get experience in other areas, but this is about retaining them for our NHS. And finally, making sure expectation 3 is about the deployment of the staff, making sure it's done efficiently, it's done flexibly, like Juliet was talking about, flexible working. What does it mean? There's often lots of caveats around that. But making sure that we're minimising the agency dependency that we had become quite used to. Those specialty-specific guidance that was then produced by NHS Improvement over the years of 2016 and 2017 was published. But despite that, what we were seeing in the early days of 2018 was that places were not following the National Quality Board framework. They were picking aspects of this framework to follow. And so the Developing Workforce Safeguards was published by NHS Improvement in October 2018, and this sets out the regulatory framework by which organisations are monitored. They have 14 recommendations in the DWS, I'll call it from now on. But the primary requirement is that organisations will follow the National Quality Board framework set out here on the left in order to have the right staff with the right skills at the right time and place. And we need to make sure that we are monitoring that by having a local dashboard and also care hours per patient day as a metric to ensure that we are able to benchmark with each other. A lot of people will criticise the care hours per patient day, which was the metric that came forward from Lord Carter, because it's a blunt metric, because it divides the amount of total hours of nursing you have for the full 24 hours by the number of patients in bed at midnight. What it does provide us with is a meaningful measure that we can compare across our organisations, because it takes away that element of small wards or different size wards. It makes it benchmarkable. So it's useful from that perspective. So I'm now going to move on to talk a little bit more, break down that triangulated approach, which chief nurses have to sign that their organisation has followed in order to reach their establishments for the next financial year. So this is what we want. We want to have a balance of what the inputs and the outputs are. So inputs in terms of our staffing, the numbers, the skill mix, their education, that is balanced finally against the outputs in terms of the needs of our patients, acuity, dependency, complexity, as well as the amount of patients that we're having to get through our system. And we know that that number of patients that are coming through our system at the moment has significantly increased as we play catch-up following COVID. So from time to time, that scale will become unbalanced, one way or the other. What we have to do is minimize the amount of times that happens and have mitigation in place to be able to manage that so that quality and safety of our patients is ensured. So the strategy for an organisation to have in order to manage safe, sustainable and productive staffing very much needs to measure the National Quality Board's strategy. And that provides us with an opportunity to be able to go to our colleagues in other organisations and look at how things are happening there and what's happening with numbers and skill mix in these organisations. So that brings me to evidence-based tools. Evidence-based tools and data. So I've got some of the tools that are available. We've got the acute hospital tools, the Shelford's Safer Nursing Care tool. There's a suite of those for the different specialities. For mental health, we've got the Mental Health Optimal Staffing tool. There's 10 specialities within that. And then we've got the Community Nursing Safer Staffing tool, which is an NHS England product. All those tools that I'm talking about are free to the NHS via license. So there's no additional expense to organisations. I have to clarify here that this is about the Safer Nursing Care tool. This is not about an electronic solution that you get through an e-rostering system called Safe Care. That's although it's aligned, it is different in the way that it is used. And all the wards and departments that are used to provide the data to build these tools are taken from quality assured wards. So the first thing in developing these tools is about making sure that we recruit wards and we assess the quality of the wards, and then we only include those wards that meet those quality standards. So the adult inpatient safe nursing care tool was relaunched in October, so just a few weeks ago, and that followed 2 years of research to update the tool so that it was maintaining itself up to date for our NHS today. And in doing that, we examined 250,000 nursing activities. So we recorded at 10-minute intervals what nurses were doing on their wards, on those quality assured wards, to make sure that all of that element built up to provide the nursing resource for each of the levels of care. Those levels of care resource, therefore, contains a vast array of information when we drill down. So about how much time we spend on medicines administration, for example. What about training for our nurses? We know that student nurses provide support to our staff in the delivery of care, but they also generate a workload, and the tool captures that. We measure that while we're developing the tool. But we also know that when we're monitoring, we see nurses who are not doing anything at all to contribute to patient care while we're doing it. And a lot of people say, what? Nurses do nothing? We can't have that. We've got to stop that. Well, that's wrong. We can't stop it, and we must not stop it. In any industry out there, people will have time down during their day at work, even if it's to walk to the water cooler and they meet somebody and they have a chat. And nurses are no different. We need to do the same thing. We need to check in with our colleagues to see how we're doing. And we build that into the Safer Nursing Care tool. So we call it Ready for Action Time. And Ready for Action Time includes our meal breaks, but it also includes that time when we're checking to see how our colleagues' night out was last night, or how the wedding was that they went to at the weekend. And we know that about 7% of our time needs to be recognised that we need that. We need about 7% of downtime to prevent burnout. And that is built into the tools, and we don't want to take that away. So I'm very fortunate that I work alongside Professor Peter Griffiths, and we often lecture together. And Peter will, while he's standing there next to me, will say, the Safer Nursing Care tool is not perfect. And I absolutely agree with Peter. It's not perfect. You need to make sure you're following a triangulated approach. We know that. Professional judgment is key, and we will have to acknowledge that, because no tool is able to take into account all the intricacies of our jobs. and how we deliver patient care. So we have to make sure we are educated in how to apply the tool in practice, and that we are learning from research as it unfolds, so that we're continually updating and changing our approach. So the Safer Nursing Care tool, the MHOST tool, they're only as good as the data they produce, and the data they produce is only as good as the people that apply them in practice. So we must make sure that our 3 most senior people on our ward is educated and trained in how to apply the levels of care, and that we assess their ability to do that, so that we have confidence in their ability. We need to make sure that they're following the implementation guidance of those tools to ensure the data is valid and reliable. So the tool has in the past always said 20 days, twice a year. But the Southampton team, led by Peter, specifically looked at that. How much data was enough without overdoing it and overkill. And 20 days was enough. 30 days was better. 40 days was even better than that. And I said to Peter, right, we're updating the tool. What do we do? Do we leave it at 20 days? Do we need 40 days? Where is the sweet spot? Because we've got to balance this with data collection burden. And his suggestion back to me was 30 days, go for 30 days, Anne. But don't bother going over 40 days, because what we see once we go over 40 days is we get exhaustion. It becomes a tick box exercise, and we're not valuing it, so it becomes less reliable data. So that's evidence-based tools. Let's move on to outcomes. When we're talking about outcomes, what is important is to make sure, again, we're not feeding the beast for data. Look at what data we already collect for anything in our organisation, and then look at it through the lens of, is this nurse-sensitive data? Is that what is important? And that's our focus. So of course we will follow the NICE red flags, and I'm sure you all know the NICE red flags. You might not report on all of them, but it is ideal if you're reporting on all of them. So that's things like less than 2 RNs on a shift, or delayed medication. But other outcomes you might look at is administration errors, tissue damage, violence and aggression. That is important for our staff as well as our patients. And on the flip side of that, we need to think about what's important to know about our staff. So are people getting their mandated training, and are they getting their additional skills training? How many times is that cancelled because we haven't got enough staff? So we need to be recording that, and we need to be making sure that that is being flagged, because that, we can have the right numbers, but if we haven't got people trained and skilled, we won't be able to deliver our safe staffing agenda and quality, safe care to our patients. Making sure people get their breaks. So making sure we keep a record. If people are regularly missing their breaks, it's not good for our health and well-being if we're missing our breaks. Sickness and turnover. Sickness and turnover can be an indicator of, as you will all tell me, the stress of not having the right skills to be able to deliver the care for our patients. But it can be about the culture and the leadership within the ward. So it's not actually linked to the safe staffing, and so it's a different aspect that we need to tackle, but tackle it we must. So staff surveys, exit interviews are really great places to get information. But in my experience, probably the strongest place to get the evidence and feedback from staff that is really honest is when staff have left us about 6 months. To follow people up about 6 months later is absolutely amazing at times, because as you leave, you don't want to blot your copybook. You want to get out the door quietly. But actually, once you're gone and you've settled into your new job, you start to feel much more confident to say, what was it that was not good about that experience on the ward? Now, not everyone leaves a job because they're unhappy. Sometimes they have got some amazing stories to tell you about what was great on that unit, and you want to make sure you capitalize on that and retain it. And professional judgment is the final part of that triangulated approach. Professional judgment is really poorly understood. People are not quite sure what it means. And Dreyfus says that it's about theory and experience. So it's a combination of the two. And I like to think of that then as where our experienced senior nurses are able to provide us with a series of prompts that helps us and helps more junior colleagues with their decision making, in this instance around safer staffing. And Christine Saville, Peter Griffiths and colleagues produced a professional judgment framework, which is down here. It's a guide to applying professional judgment in practice. It's available on the NHS England website. If you go to NHS England, tap in safer staffing, you'll be able to find it there. And the reason why it's on the NHS England site is because the National Quality Board has approved it. Only National Quality Board approved guidance will be on the NHS England website, because it goes back to Francis. Francis said everything that is coming out from you has to be NQB approved. So we retain that link. So some of the things that are in there, I'm not going to go through them all, but for example, would be about ward layout. So the tool has recommended X number of staff, and you, in your professional judgment, will think, well, my ward is a really difficult ward because it's based over 2 floors, or there's a big corridor down between the 2 units, you know, various ways, the old-fashioned wards that we have and we still live with. So that requires a different approach and a different way of allocating staff. So we need to take that into consideration. We need to think about skill mix. Now, a lot of our skill mix decisions will be driven by the acuity and dependency of our patients. So the sicker, more acutely unwell patients will drive us to have an increased need for registered nursing. And we might need to have more support workers when we start looking at the more dependent patients. Or the rehab unit, we might start to say we need to have some occupational health therapists, or not occupational health, occupational therapists, or physiotherapists. So being flexible. And we have to acknowledge here about nursing associates. So we have registered nurses, nursing associates, healthcare support workers. Nursing associates do not replace or substitute registered nursing, but they do have a place. And we have to recognize that their place is there to help us and support the registered nurse in providing safe and effective care for our patients. But if you are going to introduce this role into your team, you need to do a quality impact assessment, and you need to monitor that quality impact assessment to make sure that your gut instinct, your professional thoughts about having that role in your team is safe and is providing quality care. Ratios. How many people here have heard of the ratios set by NICE when they did their safe staffing guideline? Anyone? Got one? Anyone say a few there? What was it? 1:8. 1:8. And after that guideline came out, and I went out across England and I talked to chief nurses and said, how do you know your staffing is safe? How do you know you've got enough nurses and you've got enough registered nurses? They told me they knew that it was safe because they never breached the 1 to 8 rule. Now, at the time that guideline came out, I was still working at University College Hospitals London. And I had been on the group I was on the NICE group that developed that guideline. And when I spoke to my chief nurse, Catherine Fenton, at the time, I said, right, it's 1 to 8, blah, blah, blah. And she said, right, we can't go to 1 to 8 then. So when we're setting our establishments, we've got to make sure we're at 1 to 7, because 1 to 8 is the tipping point where harm may be occurring to our patients. So 1 to 8 was our sense check to make sure we weren't breaching. And at times, people said, I'm okay with it not being 1 to 8, 1 to 7. I'm okay to change it. And this is the reason why, and that's fine. And I know that the exact same practice was put into place by Dame Hilary Chapman up in Sheffield. She also went to the 1 to 7. We need to do it, have our sense check before we get to the point where harm may occur. And ratios absolutely has a place in our sense checking for staffing. But on its own, it's like the tools. It's too blunt. We have to have our professional judgment. Furthermore, when we do our acute independency using the tools, we see that there's a great variation. Anything from 1 to 4 to 1 to 11 sometimes is the ratios that might be recommended based on the patient needs. So the sense check of it is important. But what was interesting to me when I look at that is that that was exactly the message that Peter Griffiths and his team gave to the NICE committee, that there was a variation, there was a range of ratios that was suitable for adult inpatient wards. And finally, care hours per patient day. Are we okay for time? Okay, we're out of time. Right, okay, so let's move on then. So we need to have this report that is sent to all the people so that we can have a professional discussion. And at that professional discussion, it's not just nurses, it's the ward nurses, the matrons, the divisional nurses, but it's also our finance colleagues and our workforce colleagues, because they need to help us with doing the financial forecast and also setting up the recruitment. This is an establishment setting cycle that I'm not going to go through. The main point I want to share about this one is that you need to make sure that it fits with your annual budget resetting time, so that whatever you are saying you need, you're getting that message in there before the budget is allocated out. And then that brings you to the deployment of the staff, and it follows exactly the same process, the triangulated approach, to make sure that your roster is directly linked to the establishment that you agreed. So I am really speeding up here now. So how can we help you at NHS England, and particularly how can this CNO Safer Staffing faculty help you? So we have the implementation guidance for all the tools. We provide webinars. We have trust training available for all the organizations, and we provide advice and support as you ask. We also have this year published the e-learning program for the fundamentals of safer staffing. And that provides the main principles underpinning the policy context and the other considerations that we need to describe in terms of the links with patient safety, quality care, staff deployment, and good governance. And this is available to everyone, and the link is here, and you can get it from our NHSE website. Gone the wrong way. We also provide if you want to take that step further, we have the introductory module, and we have the master's program in healthcare workforce planning, delivery and assurance, which was the CNO Safer Staffing Fellowship program. That is delivered in 3 layers. You can step off from the postgraduate certificate or the diploma, or go straight on to the master's. And our fellows are senior nurses and midwives across the country, across all the specialities. They're aspiring nurse directors, they're aspiring leaders in safer staffing. They all have a passion to embed evidence-based practice. And the short-term or the medium-term vision from Dame Ruth May is that we will have a fellow in every organisation in the country. And it's great to see so many fellows here in the room today. This is a bit about the programme. You can look at this in more detail, and I'm happy to have a conversation with you if you want to get in contact. The best way to get in contact is the email address that's in red here. So I've really sped through the last part there, but that's it. Thank you very much.
Great, thank you very much, Anne. Really, really fascinating stuff on safe staffing. I'm afraid we've come to the end. Essentially, we have to change this room into the awards very quickly so that it will look all sparkly and amazing. So thank you very much. Anne Casey, MBE, everybody. We've come to the end of Nursing Times Workforce Summit 2023. Hope you enjoyed the experience. Covered a lot of topics and a lot of ground under the umbrella of workforce. Expect I'll see some of you at the Nursing Times Workforce Awards in a bit. If not, hope to see you at the summit next year. So just a reminder, the drinks reception starts at 6:45, VIP one at 6:30. Thank you on behalf of Nursing Times.